TAVR was first introduced for inoperable patients before it eventually ended up in high risk but operable patients. Because of that, we now have some really good long-term data on those high-risk patients. And so in the September 22nd issue of JACC, there was a paper and accompanying editorial comment on TAVR, lessons learned from extreme risk patients. The editorial comment is by Thomas Pilgrim, MD, and Stephen Windecker, MD. So let me introduce you to Thomas Pilgrim, MD, who's an associate professor in Bern University Hospital and University of Bern in Switzerland. Now, this is an analysis of CoreValve data, so let's start talking about what Yakubov and colleagues reported, and then we'll talk about what we can learn from their work.
Okay, yes, thanks for having me. We're talking about, in the CoreValve extreme risk study, we're talking about a prospective registry of patients treated with a self-expandable valve as compared to a balloon expandable valve that has been investigated in the partner trials. And Yakubov and colleagues present now the 2-year data of approximately 500 patients treated with the self-expandable CoreValve in patients at extreme risk for mortality. So we're talking about patients that are supposed to have a risk exceeding 50% mortality risk at 30 days if they would undergo surgical aortic valve implantation. And what they showed is that actually the results were pretty good. They had very few cases of valve deteriorations only. And I think in a nutshell, the main outcome can be summarized as such that the outcome was limited rather by comorbid conditions rather than by valve deterioration.
So that's good news. What can we take away from this? Because you had a really good editorial comment that accompanied this paper.
So I think, so what is important to see, I think, is that TAVI started at very high-risk patients, was introduced in very high-risk patients as compared to, for example, percutaneous coronary intervention. Now we're moving slowly down to low-risk patients, but at the same time, it also gives us our good peri-procedural results also give us the opportunity to investigate TAVI at highest risk patients, extreme risk patients, where we are really unsure whether it's still worth to do an intervention or not.
I mean, to a degree, the findings of the present analysis are a little historical in terms of recent device iterations have now come along that have made this a little bit, but we can still learn from it, is what you're saying.
Exactly. I think there are a few limitations of the study. I mean, as you have said, the data is more historical. There are still some challenges of this transcatheter technique, such as, for example, access site complications, bleeding complications that now have been addressed by refinement of the delivery catheters, by smaller sheath catheters. For example, we're not using this 18 French sheath anymore for the CoreValve, but rather like 14 sheath. The second issue is bleeding complications that comes with the diameter of the access site. The second issue that is very important is surely the occurrence of paravalvular regurgitation after transcatheter aortic valve implantation. That also has been associated with adverse clinical outcome. But what the authors have seen in this study is that there was no increase in paravalvular regurgitation between 1 year and 2 years, so it was pretty much stable.
Now, one thing you noted in your editorial comment is that it is critical to differentiate between extreme risk interventions on one side and futile interventions on the other. Do we learn anything from this that helps in that distinction?
Yeah, I think, indeed, I think the biggest challenge in TAVI right now is probably patient selection. So who might benefit and who might not benefit from TAVI? I think first, if we look at the patient, we have to look at the patient on an individual basis, but we have to first decide, is the aortic stenosis really his main problem that limits his quality of life? And I think in patients older than 80 years of age, we're talking about quality of life mainly. And if we see that the quality of life is compromised due to symptoms related to severe aortic stenosis, and if the life expectancy is not less than 1 year due to other comorbid conditions, it's probably worth it doing transcatheter aortic valve implantation. First, to improve symptoms of the patients and also to decrease rehospitalizations.
Well, I think it's a great paper, and I would really like to thank you for the editorial comment too. This is in the September 22nd issue of JACC. Please look for the paper by Yakubov and the the document by Dr. Pilgrim and Dr. Windecker in terms of the editorial comment. From ESC, I'm Rick McGuire. I'm the executive editor of CardioSource World News.